Good afternoon and welcome to the Commission on Accreditation of Allied Health Education Programs webinar, Improving the Quality of Clinical Preceptors, Practical Applications for Bench Teaching. This session will run approximately 60 minutes. You will have an opportunity to ask questions at the end of the program, and we will try to answer as many as possible within our limited time. Speaker contact information will also be provided so you can ask follow-up questions as needed. Questions can be typed into the question area on the GoToWebinar control panel. We are very fortunate to have Dr. Donald Simpson, who is a certified cytotechnologist and also holds a master's degree in public health, as our speaker today. He is chairman and cytotechnology program director, associate professor at the Department of Laboratory Sciences for the College of Health-Related Professions at the University of Arkansas for Medical Sciences. He is past president of the American Society for Cytotechnology, the vice chair of the Cytotechnology Programs Review Committee of the American Society of Cytopathology, and currently chairs the Breast Care Quality Management Committee of the Arkansas Department of Health and Human Services Breast and Cervical Cancer Control Program. He has authored and co-authored 17 publications, 4 book reviews, and 58 peer-review abstracts in journals and related to pathology, pediatrics, emergency medicine, pulmonary medicine, and public health. Dr. Simpson was recently selected to participate in the 2011 Leadership Development Program of the Association of Schools of Allied Health Professions. With that, I turn it over to Don Simpson.
Muted.
Thank you very much. I appreciate the introduction and I want to welcome everyone to this webinar. Above all things, I think we share the one thing most important, and that is that we're educators and we have a passion for our students as well as those that help out in the trench, on the bench, in the respective clinical lab settings, operating rooms, the theaters of instruction that we're going to talk about today. As Lorna said, I do have contact information that I want to provide to everyone so that should you have questions or at any time want to follow up by email, which is always good, and my office phone number is on here as well. Please feel free, if we don't get a chance to answer everyone's questions, concerns, feedback, we can annotate these things out and send them back to you. Again, I appreciate your time and for logging in today to this webinar. We'll start off talking about learning and teaching. And there's a quote here from Dr. Silvius, and even though it's not clear whether Silvius was describing his teaching method in relation to a group of students or to a succession of individual students, he understood the essential features of clinical education. He understood, for example, the need for active learning in an authentic clinical setting. You'll see highlighted several words in yellow. His method is to lead, the word practice, see, hear, the word see again, questioning, notes, thoughts and perceptions, calls, principles of treatment. I think one of the things we can take away from this is that as a teacher, you're an important role model whether you wish it or not, and we're going to talk about that in more detail in a few minutes. Just as you and I, we cannot hide from the learner, so the learner's knowledge, skills, and attitudes are apparent to us. And the goal in any clinical education experience is to have created a trusting relationship so that we can discuss personal and professional attitudes and values in a way that's seldom possible in a lecture hall or with a larger group. And I think this is probably one of the key benefits of one-to-one teaching. Looking at this table, to put more objective information around a subjective statement that one-to-one teaching is really cool but often intimidating, especially for our volunteer faculty or our clinical faculty, we can look at a lecture room, and if you're able to kind of follow the mouse, in a lecture setting where it's from 0 to infinity, it's a very efficient manner of delivering. But if we go to the rightmost part of this graph, we can kind of see that the one-to-one clinical attachment, it's very low. It's not very efficient because it's that apprenticeship model. Active learning, however, is extremely high. Mutual feedback is very high, both information you've garnered as the instructor as well as from the learner's perspective. And then modeling the behavior in a real-life setting is very high. So our chances of success, I would argue, is much higher with one-to-one teaching to change behavior, to impart the information that you are trying to get across, as well as getting feedback from you. So we're going to spend most of this webinar talking about these things, and hopefully you can take away some skills to enact in your own practice. It's been said that wards, operating theaters, general practice, and community clinics provide a very real and dynamic context for active learning. And my background is the lab sciences, so some of the illustrations I'll provide deal with programs like medical technology, cytotechnology, a laboratory environment, less patient contact, but definitely behind the scenes context of healthcare. But I think all of these things generalize to students, because whether it's a patient sample or a patient having an ultrasound, or a patient in the surgical suite or in an outpatient setting, this one-to-one teaching and feedback sort of is content neutral. Okay, there's a boy there. That's my son. Our son is 11. We also have a 6-year-old daughter who take piano. Now, what does piano lessons or any type of musical things have to do with teaching? George Engel visited 70 medical schools in North America, and after visiting these schools and these programs, he basically summarized and said that if musicians learn to play their instruments, as physicians learn to interview patients, then the procedure of taking piano lessons in this case would consist of presenting in lectures or maybe a demonstration or two the theory and mechanisms of the music producing ability of the instrument, and then tell this guy on the keyboard to produce a melody. Okay? The instructor wouldn't need to be present to observe or listen to the student's efforts, but would be satisfied with the student's verbal report of what came out of the instrument. Now, sometimes that's good. You don't want to hear the noise that's created, but that's not an effective way to learn to play a piano, a violin, or any other instrument. It's not just a series of lectures. I know piano lessons that we've been blessed to attend is a one-to-one interaction, feedback, practice, feedback, practice, reflection, all of these other things that go with learning to play an instrument, I think translate really nicely to you being an effective teacher. So what makes an effective teacher? There's several things, and hopefully you'll see all of these from your perspective. Effective teachers demonstrate respect for the learner. How is this done? Well, wherever possible, I think it's important to begin our teaching moments by inviting the student to define the direction and content of the learning experience. And this conveys your confidence and my confidence in their ability to define their own learning needs and define worthwhile education material. What is our goal? What is the goal of leadership? Well, it's not to produce more followers, it's to produce more leaders. Likewise, our goal as educators, I think, is to produce lifelong, self-directed learners. And that's what makes a good healthcare practitioner, someone that's in it. They view this as a career, and they're looking at it as a lifetime of practice. Leaving the student alone in an exam room may challenge the learner to think, but it may also induce panic. Okay, eliciting thoughts, diagnostics impressions during a shared encounter. The second part of being an effective teacher is challenging your student, challenging your learner to think. And an effective teacher strategically introduces the challenge to motivate the learner. Effective teachers also, as the third bullet point brings out, encourages learners to focus on things that they can use immediately, that they can practice, and that they can take responsibility for. Lastly, effective teachers know the differences between gremlins, and that's the picture here with William Shatner, or as many would refer to Captain Kirk in an airplane from a Twilight Zone episode, where gremlins who like to mess around with aircraft, and we say other things when they go wrong, we blame it on gremlins, and gnomes. Gnomes hang out in gardens, not on the wings of aircraft. So effective teachers know the difference between gremlins and gnomes. And don't tune out just yet. I want to explain what a gnome actually is. This is our friend the gnome, and he's going to help us basically recall essential steps in organizing an educational experience. In the classroom, on the bench, on the lake, in a fishing boat, or on a bench in front of a piano. This may seem silly, but I think it's critical to understanding the culture of education, the dynamic of education, and the process of education. It represents the language and the rules of effective planning, and each of the letters in GNOME stand for an essential step in the educational planning process. So if we put a gnome, rather than a gremlin, into the everyday practice of teaching, we should improve both effectiveness and efficiency. So let's start with G. The G in GNOME stands for goals. How can we do anything, let alone have an educational endeavor, without goals? The downside is they're often very generic, and they often come from outside of the educational interaction between the teacher and learner. I equate goals to maps. They're like a map, but they're without streets. Okay? It's a map without the streets. A map of where the learner should be headed. For example, one goal for a student may be how to become an effective communicator with patients. One goal for a student may be how to, say, color align a microscope or calibrate an instrument. Another may be to become a competent physical examiner. Okay? However, your specific destination on the map and how you get there is quite another and more complex manner. Often I think goals tend to be defined by others, and they stand alone outside of the interaction, outside of this one-to-one interaction, and they're sometimes unstated or unclear. So much like the spelling of a gnome, for this reason we say that the G in GNOME is often silent. Goals are likewise silent. Let's talk about needs. Okay? A needs assessment should be the first thing that happens in any educational interaction. Needs are what? Well, they're the learner's deficit in relation to the goals. For example, we talked about the goal of maybe you helping your student become a more effective communicator, you helping your student learn to pipette. The student, as a communicator, could need to know the topics of the patient. Let's just say they're going to take a history. Maybe they need to be able to ask open questions about smoking history or other negative self-modifiable risk factors, behavioral factors. Maybe the student should feel comfortable, or you want them to feel comfortable in taking these things. There's three variables that come in terms of the N standing for needs, and that's essentially the knowledge, skills, or attitudes. You have to find out what the learner needs to know, what the learner needs to do, or what the learner needs to feel. Okay? So needs essentially drive the rest of your educational process. You have a goal for what you're doing. There are needs, not yours or mine, but the learner's, and then we move into the business of having objectives. If the goals are very general, then the objectives are very specific. We see this all the time in written form, whether it be workbooks, manuals, but our biggest challenge is to create objectives and use them in a one-to-one context of teaching. Okay? Let's say, for example, to build on the concept that we want our learner to be a more effective communicator with patients. All right, I know when I am in the context of a healthcare setting as a patient, I want an effective communicator. It doesn't matter if somebody's coming at me with a needle or a blood pressure cuff or something much more invasive than that. We want to know what's going on, right? So our students need to realize that they're very much a part of the healthcare team, and that communication is a very key attribute to be effective. So in doing a needs assessment, we can decide that the learner should be able maybe to define 7 characteristics of a chief complaint, you know, location, duration, modifying factors, quality, things like that. Or maybe we would decide that our learner should be able to ask open and focused questions appropriately. We may then get at a knowledge objective, for example. You need to have the knowledge. That's one of the objectives. The second is a skill, being able to ask questions appropriately. And this may take practice. That's why what you provide on the bench, in the clinical setting, those opportunities should be safe, and they should be reassuring, and above all, they should provide feedback. What about methods? They have to be compatible with the objectives. A learner can read and be able to define, as I mentioned, characteristics of a chief complaint. Reading helps achieve knowledge objectives. However, reading doesn't necessarily make me as a learner or your learner feel more comfortable about actually asking the question to the patient. So to feel more comfortable, you may need to talk about what's making you uncomfortable. Perhaps observe, and that's where you come in as a preceptor. Perhaps you show one. You know, the saying in healthcare, and I think to a large extent in many places this still holds, is that you see one done, you do one yourself, and then you teach one. That's where methods come into play, but your methods must be compatible with your objectives. Role-playing to help the learner practice communication skills is a very important part. The final letter in our G.N.O.M.E is E, which stands for evaluation. And this is where you ask yourself and the learner, have you accomplished what you set out to accomplish? There's really 2 purposes of evaluation. One is feedback, to provide feedback or to feed back the information or findings to the learner, to the student, to your shadow, so that he or she can adjust and try again. This we oftentimes call this the formative process of evaluation. The second purpose of evaluation is judgment. What do we mean? We're judging people? Well, essentially because students or residents or those people that we have responsibility for get a grade. They get you're going to be accountable for this, and you're going to be graded on it. It's okay to provide that. So that's what this G.N.O.M.E business is essentially all about. Okay. Now, the rationale for our whole time together today for this exchange is pretty simple. That's to get you to come up with your teaching mission statement. If you're rolling your eyes or you're thinking, oh goodness, what is this all about? You have this already. You may not have it articulated, but it's sort of your operating principle. Again, it's the map, as we talked about, in terms of the goals. So what is your teaching mission statement? I've put on here an example. You may say, I intend to teach the learner the differential diagnosis in any, whatever your content area is, from clinical cases such that they can demonstrate this reasoning strategy when seeing patients in the clinic, specimens in the lab, whatever the context is. Again, this is content neutral. It matters not what your subspecialty of allied health is, so much as having these things articulated. You want your mission statement to be relatively short, easily communicated, memorable, and frequently revisited. Often people say, you need this posted clearly in your work area. We're just doing what Socrates said, or trying to not fall into, and the quote at the bottom, the unexamined life is not worth living. Your mission statement as it relates to your teaching is essentially examining what you're doing, asking why you're doing it, and then trying to sort out what benefit it has for your learner. To build on this, we need to look at habits. I mentioned a second ago that you're a role model to your trainees, to your students. And if I'm not using the right categorization that we use often of our students or of our people we have responsibility for, then forgive me. But do you know, or did you know, that you're a role model to your trainees, to your students? Maybe you didn't realize that learners are sifting through everything you say and do, inside and outside the patient care setting. And while they're doing this, they're actually deciding what parts of your behavior they're going to incorporate into their role as a healthcare professional. Observation learning, acquired by watching others and through experimentation, is the primary way that our students develop their clinical and interpersonal skills and habits. You are conveying the culture of healthcare at your institution, the field of allied health, and giving them something that they're taking away. Think about you, okay? Think about me, think about you. Have you observed and benefited from working with other allied health professionals who consistently demonstrated the best qualities of patient care, clinical judgment, professionalism? Chances are that those men and women had some powerful role models, and they have reflected carefully on the examples that they want others to see and emulating. So we have to question, what behaviors am I modeling for my students on the bench, in the clinic, wherever it is that I'm doing this, in the trench as we're going to call it. Do you encourage self-learning, or do you micromanage the case? Do you model and teach work organization, or do you reprimand for inadequacies? Do you demonstrate and talk through the steps in the procedure, or remain quiet and then talk over when the student flounders? Do you include patients in your discussions, or assume that the physicians or somebody else can make all that decision, and that the patient has really nothing to contribute? I think the first step in becoming a positive role model, and hence a competent clinical preceptor, is to recognize our behavioral habits. And we have to realize that we're either emptying other people's buckets or we're filling them up. One moment of lost composure that translates into throwing something, using words that we might not use, snapping at someone, or belittling a patient reflects on you, it reflects on me, and it reflects ultimately on the habits and practices of our trainees. So realizing what our habits are can be habit forming for others. Example's not the main thing influencing others, it's the only thing. Okay? Another thing as it relates to this mission business is, and this is sort of one of my mission statements, and I think it's yours whether you've articulated it or not, and that's we're training our replacements. That's our goal. We want to leave it to eager beavers, okay, to carry on. We're gonna have a need for health care more and more as our patient population ages, as the demographics of society change, as the silver tsunami hits. The baby boomers hitting the health care. Oh my goodness, we could go for many, many minutes on the effect of possibly health care reform and how that's going to impact all of us. So we want to be able to train our students such that we feel comfortable with them providing care for us. Okay, I wanted to use some, again, local data. As I said, I'm most intimately familiar with the laboratory setting, and we'll talk about the workforce shortage. Okay, I want to train my replacements, and we want to put people out there to fill open positions. 43% of laboratories, and this is U.S. data, report difficulties hiring personnel. The median age of the lab workers, of a technologist in the lab, is 48 years of age. And this shortage, as I just said, is going to be exacerbated as people retire and the healthcare system gets more vigorously utilized. Okay? About a quarter of the workforce will retire in the next 10 years, and only 2 laboratorians are entering the field for every 7 that retire. So we don't have to be too good with math to understand that we're not keeping up with the demand. The Bureau of Labor Statistics projects that about 14,000 new med lab professionals will be needed per year, and the clinical lab sciences profession or employment is expected to grow by 14% by 2016, which is faster than the average for all occupations. So the number of openings is expected to continue to exceed the number of people looking for jobs, and most jobs will continue to be in hospitals, but employment will grow faster in other settings: medical and diagnostic laboratories, physician-based offices, and other ambulatory healthcare settings. Think about primary care. Think about the need for good primary care. I'm privileged to live in Arkansas, and it's a rural state, and access to health care is not enough. Access to primary care, access to preventive services is certainly the direction that we need to focus, and I think that holds true. I don't think that we're all doing a good enough job in that area, and so as these settings grow, we're going to have to keep or get qualified students out there. Now let me just say that's one of the plus sides of being an educator. We want to open up these sites and create these clinical opportunities and these one-to-one learner experiences and opportunities in those settings. So looking at NACL's data, there's a graduate shortfall. Essentially the 14,000 that I mentioned are needed every year, but current programs, accredited programs, are only turning out about 4,400, which gives a deficit yearly of about 9,000 laboratorians that are needed. It's expensive to train a student. Have you ever heard that as faculty, as either from the clinical faculty? Maybe you've said it yourself. I've heard this from many sides. It's important. It's time consuming. They're in the way. All of these excuses. It's not impossible. It's just things that we need to work around. Student rotations for CLS students range from 19 to 26 weeks. On average, there is about 50% productivity impact for the trainer in the hospital setting. Okay, don't use the word babysitter. We're going to say trainer. So assuming a CLS salary for this trainer is 50 grand, you may want to add other miscellaneous costs in there, but that may be minimal. Okay, so to train for 26 weeks or a half a year, and you're processing the termination, payout of benefits, reviewing and authorizing, getting it posted, this vacant position posted. Advertising's not cheap. Conducting interviews, having that best foot forward probably comes at a cost to most places. Processing the applicant, screening, whatever, health services, orientation and training. Just populate that list, and each bullet point we add, it's gonna drive the cost up of recruiting a new employee, and that's assuming an annual salary of 50,000. Replacement costs will range from 50 to 75,000. So we've gone from 12.5, or let's say 13,000 to train a student, to now upwards towards 75,000 to recruit a new employee, and this is how it matters on the bench. If we assume or let these assumptions that a complete internship is done, that the internship is, let's say, half of a year, 26 weeks, and using conservative estimate of 1 year salary to replace, break-even point for clinical sites is to hire 1 student for every 4 trained. So that's sort of a good working barometer for how many students do I need to hire to make it worth my while. You know, if we can hit it about 25% of those that we train, then it should work out. Looking at our institution, here's data from graduates last year and where they were in their training and where they were also hired. So some of these institutions, for example, Institution D had 8 students and they hired about 25% of them. That's pretty good. Institution B, on the other hand, didn't really fare so well. They trained 3 and hired none. So, you know, maybe they were in the hole like Institution H and K respectively, or maybe it worked out for them. Now you're thinking, well, if I take a student, I don't want to be stuck with them. Well, this protracted experience is also beneficial to, and a big selling point to, the clinical site, to the hospital, to the laboratory, to the physician's office, to the whatever setting that gives you an advantage that a student walking off the street into a lab that doesn't serve as a clinical site would not benefit from. Okay, let's say we're going to do back to the OJT model. The cost to train a non-traditional path employee for the laboratory to be eligible for certification, a minimum of 4 months of training for 1 clinical area per clinical area is needed, and a total of 1 year training for a CLS generalist equivalent. That would be at a comparable level of a student graduating from a CLS program. So the productivity loss is much higher due to the lack of a person coming in without the educational background. So you're going to have about a 75% rather than half, 50% productivity lost. So you're looking at here the FTE 75% with the 50K example, $37,500 to train 1 new employee, plus the salary cost of the individual, which pushes it upwards to $72,500. So we see the difference between having an internship for a site and investing roughly $13,000 to pulling somebody in off the street and bringing it up to speed where licensure and certification permits of being upwards towards $73,000. There's great value to an employer, to our rotation sites. I can't thank our laboratories and our preceptors and our clinical internship sites enough for their help and support of the program, because this is out of the goodness of their heart. Though there is benefit there, they do so much for our program and other programs in allied health as well. Having students helps keep procedures up to date, easy to follow. That's been some of the feedback we've received. It also assists with patient safety. You know, you've got another set of hands helping out. It keeps existing employees, as they say, sharp on their skills, knowledge, and behaviors. They're having to follow and explain procedures. You know, why are you doing this? Why do I need to do that? Those questions are coming at them, so that it keeps them on their toes. It also allows them to utilize best practice or standard work practices to model, as we said, that habit or behaviors for customer service, for courtesy, just those manners of professionalism that we want. And you get that added benefit of a pre-screen, the ability to pre-screen as a student before you hire, which is basically a protracted 4 to 5 month interview period. That's a pretty sweet deal. Some quotes from some of our clinical sites. Many of our students stay on and become valuable employees. They may one day become employees in our facility, and by training the students, we are retraining ourselves and learning along with them. I think that's very important feedback, that the technologists are stimulated and they feel like they're learning and getting new information by our students being infused into that environment. We were all students at one point in our careers, this last bullet point, and we want the students to become good practitioners who will care for us someday. I didn't say that, but I totally agree with all of these statements. So the challenge as faculty or as clinical faculty or anyone that's wearing the label of educator around his or her neck is to consider the value to your organization to provide additional rotation opportunities for your students. Think about ways that you can, not reduce the number of students, but how can we increase? How can we get more in here for all these reasons? Our program, our medical technology or our CLS program, we're in the process of standardizing these tracks because right now it's currently exclusively a one-to-one across a manifold host of options. We have a 2+2. Some places would call this a traditional track. And that just means that essentially they come here at about junior status and do their junior and senior years. There's a fast track. That's a post-baccalaureate track. Someone who has already graduated with a degree, they meet the GPA and the prerequisite requirements. They do an accelerated one-year program. They can do it by distance. They can do it part-time. They can bridge basically from an MLT from medical lab technician to a medical technologist, and any combination thereof. I can do fast track by distance. I can do the traditional by distance and part-time, and so it gets really crazy for the faculty. So we're in the process of kind of standardizing some of what I call these tracks as attendance options, okay, both from a process standpoint, improving the process, and to keep customer service involved such that the students feel that it's the right program and it meets their needs. One of the things I wanted to point out about this is that you can look at this traditional, this 2+2, across just a 3-year period where there were 12, then 11, then 7. So you see a decline in this data point, but the fast track bumped from 5 to 9 to 13. Some people would say, oh, that's 100% increase in students. And as a result, as we can see with these others, we have to modify the internships, modify the clinical time as well as the didactic time accordingly to meet the needs of these students. Looking at some of the outcomes, attrition has remained pretty consistent, but our pass rates for certification has increased a little bit. I know we're only talking a couple of data points, but over time it's going to be interesting to watch. These things, your outcomes, should feed back into what are we doing, and are we doing it okay, or can we do it better? So again, look at this as in terms of the feedback, both from a formative standpoint and for making a judgment on evaluation of your programs, as well as utilizing it in the trench or on the bench. What's some of the methodology about being a preceptor? How can I be effective? How can I be, as we talked about, I want to be more effective in these areas. There's 5 P's of effective teaching. Being prepared, these perceptions, okay, the concept of professionalism, the presentation of what you're doing, and participation. Learning is active, okay? It's very verby, if we want to say that. What does preparation mean, this P? Well, we have to determine the needs of students. We don't just all of a sudden show up at work and
Unmuted.
I wanted to apologize. Hopefully you can hear me, Don. We've lost your audio.
Okay.
I'm sorry, Don, we lost your audio there for a moment. If you could just go back to the beginning of preparation.
Sure.
I'm
Can
sorry.
you hear me now?
Yes, thank you.
Great, not a problem. I just saw that pop up, and I didn't want to go like 5 more minutes and you hear nothing. In being prepared, preparation is just that. Are you prepared? Okay, without borrowing from Boy Scouts, what are the needs of our students? How can we integrate previous learning into the present lesson? This is the block by block, line upon line, precept upon precept portion of your style. What is the educational level of the students? Where are they? Where do they need to be? I've always said that as an educator, I'm a coach. Now, I'm not talking about a football or that kind of coach. I'm talking about a buggy with wheels on it, that transported buy a horse-drawn coach, people of importance from where they are to where they want to be. And that's essentially what you're doing. You are determining the educational level of your students, and you're getting them to where they need to be, moving them from where you are. And then you're doing that with the tools that you need. You assemble the teaching accessories. And again, we don't just wake up in the morning and say, oh no, today's the 24th of February, I've got students. We have to put a little thought, a little effort into it. I'm going to move to the next slide. Perceptions, okay, both of the student and your perceptions. We have to integrate one's ideals during teaching and positively reinforce the practice of medicine, the practice of healthcare, the practice of nursing, the practice of pharmacy, the practice of public health. And as I said about our habits and behaviors, attitudes are very easily conveyed, and perception is a very important part of being an effective teacher. Professionalism, well, that's easy. That's clean clothes, right? I took a bath, I've got a clean lab coat on, my scrubs are starched, therefore it's all taken care of. I don't know. I don't think so. I think demeanor is important. Appearance is a part of professionalism. You know, we don't want to show up in shorts and flip-flops, right? From the patient's perspective, everybody's got their own dress code, so appearance is part of that. Demeanor, it's okay to be friendly, it's okay to be polite, but we don't want to scare people either, okay? Preceptors are usually addressed by, you know, Mr. and Mrs. Doctor. Personally, I have no problem and would address you accordingly, but I don't like to be called except by Don. Okay, that's just me. Some people fault that, others think that's cool. I don't know. Whatever this one-to-one relationship works. When you're working as collaborators in the educational process, I think that we don't need to add additional layers of any hierarchy. They know that you're the instructor and you know that they're the student, and so this role just needs to play out such that we can get learning across rather than worrying about who we are and what pecking order may ensue. Others have different ideas. Regardless, knowing the student's name is important. How many times has your name been mispronounced, possibly first or last name, or what it is you're doing? Knowing a student's name, saying their name, making them feel part of the healthcare team, I think is a very important part of being professional. What about the presentation? We are competing for a student's interest. We have competing material. I argue that students have become very proficient managers of their education and their college experience. They juggle so many balls that oftentimes this is just one more ball in the air to juggle of things I need to do, and they're busy managing the experience rather than learning or taking things away from the experience. So we have to focus on students' attention. We have to provide a positive learning environment and really convey 3 points of presentation. When you first meet them, when they just show up in your area, and you have the task of indoctrinating them, I think it's very important that you convey what you're going to do, how you're going to do it, and what the students are expected to do. Okay? I'm going to show you how to stain these slides. This is how you're going to do it. You're going to use this rack, you're going to use these reagents, and I expect you to do 100 of these by lunch. Okay, it's okay to have expectations, but that's part of your presentations. Cover these 3 points: what you're going to do, how you're going to do it, and what they're expected to do. This goes on the this applies really to the student and to the preceptor. What you're going to do, i.e. the student, and then what you, meaning me, what I'm going to do is I'm going to show you how to do this. Okay, I'm going to show you twice. I'm going to explain what I'm doing, and then I'm going to give you an opportunity to do accordingly. And participation, bilateral participation. Okay, it's collaborative. Maintain eye contact. Okay, questions provide feedback. Questions are a fact-finding mission. We have to orient our learners to the lesson, review past material. This is where feedback comes into play. Reflect on learning. I say I don't know all the time, but I don't leave it there. I then go find out and get back to them, okay, to a student. It's okay to say I don't know, and I want them to know that they can say I don't know. Would you not rather have a student tell you I don't know rather than just shake their head up and down and with a blank expression on their face, and you know that they don't know? It's okay. Again, establish that platform of trust, of a personal relationship, and get to the I don't know part. Give feedback as often as possible. And praise is important to the group and to the individual. So participation is also a key P in being an effective teacher. So reflecting on the 5 Ps, make adjustments for the next teaching experience. Will we get all these down? Will we do all these correctly? Not all the time, no. But if we prepare early, if we discuss our perceptions, if we're very professional in doing these things, if we design out our presentation and allow for participation, you are well on your way to becoming a more effective teacher, to improving the quality of the education as a preceptor that you're delivering. So what do we not want to do? Well, this is pretty easy. Do not give in-depth lectures, okay? That's what the classroom is for, not the bedside or the bench. That's not what it's about. It's not seminar time either, nor is it time for a formal educational session and extensive discussion, or as we would say, a beat down, okay? It's not appropriate to do these things in a clinical setting. Efficient and effective bench teaching requires that the student and you accept the limitations of the setting, okay? I think it's important to realize that. There's no one ideal or optimal classroom setting. It doesn't exist. That's why you have to realize the limitations and capitalize on that. For example, in an outpatient ambulatory care setting, a discussion about a differential diagnosis, well, it may be a lymphoma or it could be melanoma, okay? The pathophysiology of something and psychosocial problems are not possible nor necessarily desirable. So you have to understand that you accept the limitations of the setting and that your student understand that too, okay? This is the place and time piece of being an effective preceptor. Demonstrate enthusiasm, give meaningful, authentic responsibility, not, hey, would you sharpen these pencils? That's, wow, we need that done. That's not very meaningful, okay? It's important to do. Let them do something, and then you take the, as we would say, the scut work role. I find that that's a big boost a lot of times to confidence as well as self-esteem. You know, I'll take care of that. You do this. You know, I'll take care of the this or the that. And our clinical skills need to be credible. Okay, if you're not doing your proficiency testing, if you're not involved clinically, it may pose light on the clinical skills aspect as far as being an effective preceptor. I've always said that an expert is someone that knew something 10 years ago, so we don't want to be experts. We want to be credible. We want to have our clinical skills at least as sharp as our student.
I apologize again for the audio situation, Don. I don't know if you can hear me, but we've lost you again.
Okay.
I'm sorry, Don. If maybe the first 3 bullets or so, you faded out again.
On the pitfalls or back?
Back. I'm sorry. Yeah.
Okay. This way?
Yeah.
Are we there?
Mm-hmm.
Okay. I think it's important that we demonstrate and are genuinely enthusiastic, that we allow our students to have authentic responsibility, not just be responsible for sharpening pencils or something like that. I would challenge every one of you guys on the call to you do a scut work thing and let the student do a big boy or girl activity, and just watch how their self-esteem and confidence in what it is they're doing is boosted, and our clinical skills have to be credible. If you're still with me, if you can hear me, I think it's important that we maintain our proficiency. If we're testing, of course, being in the clinical setting, you guys are up to speed and are on the cutting edge of what you're doing, but our credibility is very important in terms of knowledge and attitudes and skills. There's several things that we have to look out for in this one-to-one interaction or this case-based teaching. First thing that people like to do is take over. It's like, no, you're not doing that right. Let me show you. We just jump in rather than just sit back. I remember watching an ER physician instruct a resident on how to intubate a patient. Now, here's a attending who's not very far out of a fellowship watching a resident who's not very far out of medical school ram a piece of metal down in a guy's mouth, and he's telling him to go slow. He's at the foot of the bed, and the patient's laying there being intubated, and the ER physician, the attending, you could tell he wanted to jump in and do it. That's why he was there. That's why he's a physician. He wanted to take over this case. But he was very calm. He had his arms crossed. He intentionally was across the room so he wouldn't just jump right in and move the resident out of the way. And he waited. He knew that the patient was not in that much distress, meaning it wasn't, he had time to teach this procedure. Okay? It's not the place to take over. It's not the place to give inappropriate lectures or scolding. And oftentimes we don't want to wait. 3 seconds, 5 seconds is a long time, but that period of silence is very important to get the answer out. A lot of times then we have our pre-programmed answers, and we don't want to do those. What do you think's going on? Could it be an ulcer? Have you thought about this? We just want to move on to the next case. Sorry, I was just snapping my fingers, so if that was a distraction, I apologize. We want to move on, and we can't do that in one-to-one teaching or clinic-based, case-based teaching. A rapid reward. Okay, we want to solve the mystery and put it to bed. What does this do? Well, it's really cool that we can do that, but effectively it ends the student's thinking process. The synapses didn't fire. They didn't get it connected. Often, though, we push past the ability. We persist in carrying the students beyond their understanding of what is being asked. So we have to watch out for these pitfalls and guard against them as preceptors. Fred Miser came out with a nice paper, and the references are also included at the end of the presentation. It was called Micro Skills of the 1-Minute Preceptor. And essentially there are 5 things, and these are the things we've been talking about for the past 40 minutes. As a preceptor, we essentially want to do 3 things, okay, with our student. Okay, we want to assess the situation we're in. If it's a patient, then you want to diagnose the patient, right? If it's a lab specimen, you want to figure out what it is and what's going on and what answers you need. Secondly, you want to diagnose the student, the strengths and the needs, and then you want to teach the student based on these identified needs. And these 5 micro skills, okay, can be used for teaching students effectively, teaching students efficiently, after they've seen a case of whatever it is you're teaching and are presenting it or working through it with you. The first micro skill is to get a commitment. After the student's presented the information to you or discussed what's going on, the first task is to get him or her to commit to a decision. What is it? What's your plan of action? What are you going to do? And this step encourages the student to take responsibility. It demonstrates that you value the student, that you value his or her help, and promote satisfaction. Useful questions that you may use during this step are, what do you think's going on? What do you think's going on? Or what would you like to do next? Their answers to these questions allow you to determine how they view the case, and parenthetically, or the situation, or what it is they're doing, the test. So be careful not to ask for more data about the patient, and don't provide the answer. Don't give it away. Okay? Second micro skill is to probe for supporting evidence. After the student's committed, made that commitment, ask them to provide evidence. Okay? you can determine whether they made a lucky guess or truly have a handle on it. That's where your skills come in for sure. This isn't the time to ask them for textbook knowledge. You know, don't ask what does this person say or what does this book say. The purpose of this micro skill is to help you identify the strengths and needs of the students by probing for supporting information. It also allows you to tailor what you need to teach about the case. Useful questions might include, well, what led you to that conclusion? You know, that's good. You know, what do you think it is? What got you there? Why do you think that? What else did you consider and rule out? What are the differential diagnoses? You know, answers to these questions give you insight as the preceptor, and it allows for good dialogue with the student. Okay. The third micro skill, tell them what they did right. It reminds us to provide positive feedback, something they want but they often don't get. Okay, comment specifically on what they did right. Describe the positive effect of the action. Okay, you did a good job of, and this is why it is important. You know, state specifically what was done well and why it's important. This isn't general praise. This isn't butt kissing or blowing sunshine. This is specific behaviors that are getting focused on, that are reproducible. You know, if you say you did a good job of this, and this is why this is important, you know, that then will be a reproducible result that the student students learn from. The fourth micro skill is to teach general rules. Okay, based on now what you've learned about your students' needs, you will now want to teach based on their level of understanding, which greatly increases retention. The 11-year-old learns piano differently than the 6-year-old. For the 6-year-old, it's a game. It's fun. For the 11-year-old, it's a contest. Okay, it's a competitive kind of thing. So the teaching styles are different. Same here. The student needs where they are, where they want to be. That increases their level of understanding, which increases then their retention of the information. The key features of this illness is, or when this happens, do this. Okay, this is where the troubleshooting comes into play by working with the general rules. The teaching point should help the student generalize this case or situations to the others that they see. It should be brief, and it shouldn't include everything you know about the subject. Okay, it addresses the patient's concerns and the student's needs. We need to minimize anecdotes, or as we say, zebras. Okay, this is about the horses when we hear hooves, not the zebras. And as we prepare for this micro skill, I think it's important to ask ourselves, what one teaching point do I want the student to leave this patient, case, fill in the blank, encounter with? What is the take home? Okay. The fifth point is to correct errors. The micro skill here is to provide feedback. If during the presentation the student messes up, makes an error, has an opportunity for improvement, correct it. Okay. Uncorrected mistakes will be repeated. Describe what was wrong, identify how to avoid and correct the error. Don't just say, boy, you're stupid, you're hopeless, I'll be glad when this rotation's over. Say, next time this happens, try this. Okay? These recommendations of positive feedback should focus on improvement. They should be future-oriented. Too often we're past-oriented. You know, we're warm fuzzy. Okay, you did an excellent job of. Reinforce what was correct. Okay, when this happens, do this. Teach those general rules. Instruct. And whoops, next time this happens, try this. Okay, correct the mistakes. Okay, so there's a lot of assessment going on and a lot of feedback. Okay, and these skills I think will enhance our teaching encounters, and I think if we incorporate that into our clinical teaching, we can only benefit from it. So here's the quiz. Okay, what do we want to do? Get a commitment, probe for evidence, tell them what they did right, teach the general rule, and correct errors as they were there. trainees, our students, do not perform required skills incorrectly on purpose. I've never met a student that said, when I woke up this morning, I wanted to come in here and screw this up beyond repair. No, they don't think that way. Errors in performance are typically the result of insufficient feedback. They, meaning the errors, not the students, are seldom the result of insufficient interest or caring, especially in healthcare. So, question and answer. Information you provide to learners about their clinical performance that is intended to guide their future clinical performance is feedback. And this is what it looks like. Since some of us are hungry, some of us are hungry all the time. Okay, here's what feedback looks like. It comes in the form of a sandwich. The top bun tells what was done right. Okay, the meat of your feedback, or the bulk of your feedback sandwich, focuses on what needs improvement. And then the bun that kind of holds the bottom up is what to do next time, future orientation for providing feedback. Here's a quick checklist. Make sure the learner's ready. Give feedback soon and often. Link it to goals. Be specific, non-judgmental. Be positive. Don't give too much. I mean, you can overload with feedback as well. And expect learners to develop skills in self-evaluation. I want to share lastly a case study of our institution and my personal experience in working with our clinical preceptors and our sites. The biggest thing in selling bench teaching or clinical education is, as I stated earlier, the source of potential employees. It keeps staff up to date, current on their theory. It also helps promote and the professionalism, the reputation of your facility, their facility. It increases job satisfaction and the self-esteem of staff, and it's just a professional responsibility. Our job as practitioners in allied health isn't to go out and not give back. Our goal is to go out and give back. Somebody somewhere cared enough to teach us what we know. It's only right that we pass that along. The disadvantages, as I've alluded to, you use more supplies. It is expensive. It does increase your daily duties on already overworked professionals, and oftentimes there's staff resistance. Not everybody are teachers. Not everybody wants to mess with students. Not everybody shares our philosophy of being coaches or educators. To make internships successful, students need to feel welcome. They need to be reassured as they progress. We've beat that horse to death already. We need to keep the roles of instructor and student well defined. This is where professionalism comes in. And select instructors, if you can, at your sites. Select those who have patience, who have positive attitudes, and who want to teach. They may want to teach, but they have no patience. They may want to teach, but they're not competent. Okay, all these things have to be sort of sorted out at your individual workplace. And have an orientation on the first day. Cover the stuff, like in our labs. We cover the safety regulations. We talk about the lab or hospital regs, dress code, expectations, exam dates, introductions of people. Always put together a composite pictures of people in the lab and give it to the students ahead of time so they can start putting face and names together. We recognize faces, we don't remember names, and I do that for the labs as well so they can hang it up and see, oh, here's the students. Okay. As a site, as a program, we provide support to the clinical rotation site. Okay, we give them the internship manual, which has evaluation forms, learning objectives. It's complete with study questions for each discipline, each rotation, and answer keys. There's a list of required tests, and we also provide the examination. So you want to provide as much support as a program as you can. A schedule, expectations are provided. Each site's given a schedule template. The practical exams, the dates for the exams. We provide the grades. For example, the grades that are needed from the clinical rotation, like the practicals. We assist with the practicals if they need, or give guidance on, if you don't have serum or controls, then use these photos, or here's some CD images. And then we help them with these designs. This feedback in terms of the judgment practical examination, it's an objective assessment of technical performance. Worksheets are often used. Students need to interpret and assess, and you can grade on oral responses or on observations. Yes, you shook that tube right. No, you didn't. Yes, that's a good response. Okay. And then here's an example of maybe a course grade. 30% for an exam, 45% of the total would count from the lab practical, and 25% from the performance evaluation. Be sure to review the evaluation with the students. Have them sign all forms, because feedback and documentation is very important in education. Students like helpful, enthusiastic, and pleasant text. They also like their questions when their questions are well received, when they're treated with respect, when they receive praise for doing well, and when they need help, that they receive patient and kind guidance. What they don't like is being called the student. Oh no, it's the student. That's like saying, oh no, it's the flu. They don't like having nothing to do. They don't like to read procedure manuals for extended periods. They don't like being left alone in an area. They don't like not knowing expectations, and they don't like inconsistency. I'm going to wrap this up by saying that we remember 20% of what we hear, 30% of what we see, 50%, about half of what we see and hear, 70% of what we participate in or say, and 90% of what we say and do. So learning has not occurred, really learning has not occurred, unless learners change their behaviors as a result of what we do. So students need to perform tests. They need to get their hands dirty in a safe environment that your clinical site provides. When do you let students do patient work? Well, when, meaning we say when their rotation has been completed and they've passed. For example, they've been successful in blood bank, they've been successful in micro. If there is time after teaching, if there's time to assist, you have to be comfortable with that decision at your site. You've got medical legal issues to work through. I'm sure it doesn't need to be the same for each student. Sally got to do this, but Johnny, he wasn't able to. Okay, results then need to be verified as well. Don't just don't just let them loose and then send it out. Now, at this time, if there's questions, I know we're getting short on time. I'd be happy to try to answer any questions you may have, and then, as I said, email or call and we can discuss further. Lorna, I'm going to turn it back over to you.
Thanks, Don. There is just one question, and as we have gone over time, I'd like to go ahead and I will email that to you, and then we could respond to that person all together. And I want to thank Don for providing us some wonderful information. I do apologize for the audio situation that we have had, and I welcome your feedback, so please do answer the few questions that you will receive, and thank you for attending. Thanks again, Don.
Thanks, everyone, and have a good rest of the week.